There are about 200,000 cases a year of rheumatoid arthritis in the United States. However, I think the disease is far more prominent on the radar screen of managed care because of the cost of therapy. Certainly when I look at high-cost claims lists, which I do probably multiple times a week, RA is usually on the pharmacy side in at least the top 10, possibly the top 15. And certainly for many employers, it's one of the top 5 condition areas, of course, depending upon their population. Most of the symptoms and signs of rheumatoid arthritis revolve around things like pain, soreness in the joints, morning stiffness, particularly mobility and functionality. So the kind of treatments we're looking at, the kind of treatments that have evolved over the last 15 or 20 years, really focus on how we make the individual more mobile, better able to function, and better able to accomplish his or her activities of daily living. Once a patient is diagnosed with rheumatoid arthritis, we do have many tools that we use to help educate the member. Rheumatoid arthritis is a complex condition. It's a lifelong condition, and certainly we need to make sure that individuals understand why they have it, what to expect, the kind of treatments that are available. We have a combination of nurses, medical directors, and pharmacists who reach out to members, of course, depending upon their level of severity and the type of treatment they're getting. But we think that getting the member/consumer in the center of that interaction so that they really are part of designing the treatment plan, but also making sure that the treatment plan is going to be effective. That's really critical, because remember, treating arthritis as a lifelong condition involves much more than just drugs. It really involves both lifestyle management, understanding the course of the disease, and making sure that the individual understands the importance of therapy so he or she can be maximally adherent and compliant. Like probably many, if not most conditions, early diagnosis and treatment has significant advantages. Certainly there are some conditions where early treatment really won't make a big difference in the long run, but when you look at the pathophysiology of rheumatoid arthritis and what leads to the symptoms of pain and lack of mobility and functionality, that relates very heavily to the buildup of fibrosis and the problems that people experience with the joints. So the point of that is that treating it earlier will ideally head off some of that, or at least attenuate the development of the joint stiffness and soreness and problems with mobility. More and more, the emphasis is on how we can understand who is going to be benefiting from treatment at an earlier stage, and then once those people are identified, getting them into the right treatment as quickly as possible. The American College of Rheumatology guidelines, the ACR guidelines, are important to managed care. We want to make sure that the policies we develop are evidence-based and that we're sharing that information not only with the physicians who treat our members, but also our members as well. More and more, I think individuals understand that there are well-accepted ways of treating conditions, especially long-term conditions like rheumatoid arthritis. And so making sure that there's transparency around that is a very important piece. Also, as we develop our medical policies, we want to be sure that they are reflecting the current standard of care and really are in line with what the expert associations in the United States recommend. One of the biggest challenges that we have as we develop our medical policies and try and understand how various treatments fit into the treatment algorithm as laid out in, for example, the ACR guidelines, is understanding how drugs compare head-to-head. That has been a challenge, I think, for decades. There is very little true head-to-head clinical trial data available. Certainly, as a new drug comes to market, it has to have data versus placebo. That's what the FDA requires. But of course, the challenge for the clinician in the office is he or she has been using drug A, now there's drug B. How does it compare one to another in terms of moving patients either towards one or the other? That's a challenge for clinicians who want to make sure that they're giving their patients the best treatments, but at the same time, do they take a risk on a new drug that they're not familiar with, or do they use the drug that they've had in their armamentarium for many years, even though they know that it's not perfect and has its limitations? I think as we develop more head-to-head trial data and as it becomes available, and also I think as it becomes an expectation, it'll be easier to make those clinical assessments. It'll be easier for managed care to develop formularies that really focus on the drugs that are going to be delivering the optimal clinical benefit. And of course, it also will help us understand value being that interplay between clinical benefit and cost.